Hey everybody, this is Dr. Paul Thomas of Plum Health, and today I'm joined by Lisa Gallagher. She's a large group practice leader with Kapnick, and we're so honored to have her on our program today. Thank you so much for being here.
Thank you, Paul. It's good to be here.
And we're excited for a wide-ranging conversation around what's happening in the insurance world, some consolidation, some differences between East and West in the state of Michigan, and some of the other things that you're seeing in the industry. So Thank you so much for taking the time today.
Thank you.
So let's kick it off. We were talking about the consolidation happening in the industry, and so let's take a 10,000 foot view. You're with Kapnick. Tell us a bit about Kapnick and what makes you unique in this marketplace.
Yeah, absolutely. So Kapnick Insurance Group has been around for over 75 years now. I should know the exact number, but we're fourth generation family owned.
That's
so
awesome.
We've been around for a long time. We are independently owned and operated. The Kapnick family, the fourth generation of the family is actively working in the business now. We do have other ownership of people who work or have worked at Kapnick. We don't have private equity interests. We don't have shareholders outside of the family or again, people who either work for the business or who have worked for the business, and they intend to keep it that way, which is a little bit of a difference between what's happening in the market. It can be really challenging in this environment, really since the Affordable Care Act.
Yes.
For an agency to really stay independent and have the resources that are needed to service larger, complex groups with data needs, specialization, and compliance. So we're fortunate. We are Michigan's largest independently owned agency. We partner through a network of global independent agencies called AssureX to make sure that we have that global breadth, national breadth, and expertise where we need to pull in those resources. And the Kapnick family's been great about making sure that we make investments in the things that we need to service large clients and to do it well and to do great consulting.
That's great. And then speaking about that long-term philosophy or that long-term approach to your work with your clients, how does that affect your individual clients?
So I think from the client perspective, the one thing that is maybe not obvious, but we don't have these secret side deals.
Yeah.
So when we're making recommendations for our clients, when we're talking about markets and opportunities and carrier solutions, they're agnostic.
Yes.
And so the retirement space, I think, has gotten a little more demanding of consultants to disclose, and the Consolidated Appropriations Act requires that we are disclosing certain things to our clients that we never used to have to disclose before. But there's still a lot of hidden side deals that happen in especially the PBM space.
Yeah.
Where those things don't need to be disclosed. And so there's a lot of profit-taking revenue that's driven not what's on the best interest of the client, but the recommendations are centered to those relationships where there's extra revenue that's not being disclosed. I don't particularly have a problem with revenue.
Sure.
Again, we all have to be profitable, right, to keep the lights on, to hire people, to grow.
Yes.
But we need to be open and sort of unapologetic. This is what we make on this relationship.
Yes.
And here's all of it.
I think we can all agree that pharmacy benefit managers probably should not exist. And this is one of the most egregious profit taking. So it's kind of a good, it's almost like a good straw man, or not a straw man, but it's a good target for a collective ire, because I think people are becoming more and more aware of middlemen like that and their futility in the current system. So it's a good argument to make.
Exactly.
Let's pivot a little bit and talk about the Michigan market, because we're sitting here in Royal Oak at our Royal Oak Plum Health office, and we've got our Detroit office. We also have like a Lansing, a Corona, Van Buren office. So we're heavily mid-Michigan and east side. We perceive that the Grand Rapids market is much more progressive in terms of companies trying to find out-of-the-box solutions rather than becoming, fully insured. There's more companies that are willing to become self-funded and use a direct primary care solution. So I'm wondering, as somebody who's been in the trenches, who works in this environment every day, what are you seeing that could be attributable to that perception that I have?
It's not an incorrect perception. So I'm the opposite. I've spent the last 20 years of my career in West Michigan. So I live in Holland. I work out of our Grand Rapids office, but I'm responsible for the employee benefits practice for our large cases for the whole country, really. And we are primarily sited in Michigan. Most of our clients have a Michigan headquarters, and the way that Kapnick has grown, they started in Southeast Michigan, and then they've been expanding. So I'm someone coming from the West, kind of moving east, and it was a little bit eye-opening for me to look at the book of business that we serve, the kinds of clients that we serve, and to see, what I would consider rather large clients that are fully insured still, that you can talk about self-funding with them, and they kind of shut it down. They're not comfortable with it. And this, I think, these are going to be some generalizations, but I think some of it stems from West Michigan is not as heavily influenced by unions compared to Southeast Michigan.
Sure, that's a fair point.
Right. So, a lot of times when you have to offer benefits in conjunction with, a contract and, the labor union, right, you feel there can be some practical reasons to stay fully insured from a predictability of cost and cost sharing with your union.
And the union leaders may demand, we want this type of insurance.
Correct.
For everyone.
That's correct.
That can be hard to overcome.
Correct. So some of it's that. The thing that I will say is, I think West Michigan is much more entrepreneurial.
Yeah.
And so we're at the table with these 200, 300, 400 life employers, often with the owner of the company.
Yep.
And so the owner of the company, the CFOs, they have that entrepreneurial sort of attitude. And when you start to talk about self-funding, you start to talk about up and down years and cash flow, and you start to then also talk about long-term trends for a self-funded health plan compared to long-term trends for a fully insured health plan. Their eyes open up and they're like, yeah, I'm comfortable with this. So we tend to have, senior leadership at the table. I also think West Michigan is a little more conservative, and I don't necessarily mean politically conservative, but some of our largest companies, Meyer, Hayworth, previously it was Spartan Stores, but now Spartan Nash, Amway. They're still privately owned companies that understand kind of the financial components of covering this risk themselves, taking on that risk themselves. So it's just a little bit of a different dynamic, but it's really unusual in West Michigan to see a company over 200 lives that is not self-funded or is not actively exploring being self-funded.
I'm so glad you named a number.
Yeah.
Because we ask people often, hey, at what point should people get off of a traditional insurance plan like Blue Cross, United, Cigna, Aetna, and become self-funded? And you're suggesting 200 is that number. Why does that make sense for companies to make that transition at that point?
I even think when you're over 100, you really start looking at it. And then depending on your demographics, 50 to 100 can work too. If you have, a relatively younger professional workforce, some of those demographics can really play out well for self-funding. So some of it is just, again, kind of control of your risk pool and your ability to influence risk through things like, direct primary care that you can't do in the fully insured market.
That's correct.
Some of it is the fact that once you have over 100 lives, your fully insured premium a big portion of your fully insured premium is based on the actual experience of your group anyway.
Yes.
So self-funding, you're basically saying that we're going to bet on the managing the risk of just our people versus putting our hat in the ring with this giant pool.
Indeed.
And so once you get over 100 in the fully insured market, your rates are heavily, heavily influenced on what's happening in your population anyway. So why not take control of that?
Yep.
And not kind of be almost self-funded in arrears is what I would refer to fully insured in that space, right?
Indeed.
So the cushion of being part of a big risk pool starts to diminish once you're over 100, once you're over 200. It's really only a small piece of it. So all you're doing is you're managing cash flow differently once you're over 200. So those, I think, are some of the reasons why. Now, some of the risks, the smaller you get, is, and I'm not an underwriter, so if you have underwriters listening to this, they're probably all gonna just, get mad at what I'm about to say.
That's okay, say it anyways.
But it's something called credibility, which is the idea that you can use what happened in the past to predict what's going to happen in the future. So when you're helping a company set a budget, the smaller your risk pool, the smaller your group of insured people, the longer it takes to become credible. And so the longer that it takes to sometimes get legs under that self-funded plan and make that CFO feel comfortable, because you have the ebbs and flows of high cost claims and shock claims and, the random hemophiliac that might come up. And these are really big problems for a self-funded health plan to solve. They hit cash flow hard.
But they can add in a stop loss policy, correct?
Yes, you can.
And then what are some other ways that they can, keep the cost more predictable as they make that self-funded transition?
So I think stop loss is a big piece of it, right? There's two kinds of stop loss. One is to protect you against any one person having really high dollars. And so setting that number in the correct space for the again, the cash flow needs and the risk comfort of the organization is really important. And then there's an aggregate stop loss component, which is kind of protecting the budget. So, we think you're going to spend $100. We're going to ensure that you don't spend more than $120. So there's a little bit of a buffer in there that you can ensure. I would say the lower that you have that individual deductible set at, that high cost claimant, and the narrower your gap between your budget and the aggregate protection, the more you start to look like fully insured.
Yep.
And the higher your fixed costs are going to be, right? So as you progress it's healthy for a self-funded plan to look to increase the risk that they take on, because again, over time you do become more predictable, and it's going to vary business by business. Some of the largest companies I've worked with have no stop loss insurance. They're very comfortable with that.
Wow. It's incredible.
Yeah. One of the other things that smaller self-funded plans tend to look at are captive arrangements. And so a captive, again, it's the idea of you're sharing a risk pool with hopefully like-minded employers that are all engaged in putting things in their health plan that can help control and mitigate cost. And you also share in the rewards of that. So you've got ownership in your risk management.
That's great.
I think captives work really, really well in the workers' comp space, where employers have a little more direct control over, the workplace conditions. Captives are not necessarily this magical solution for health plans, but they're a tool. They can be a really good philosophical fit for certain companies. And I think a lot of companies like the idea that if we outperform where we thought our risk was going to be this year, I might get a piece of that back. So there's lots of different captives in the market. Some of them are focused on construction companies specifically. So a lot of different options out there.
Yeah. Another element of this transition, we're working with a group of 75 employees, and they've they're working through self-funding and also using a third-party administrator to help, manage downstream costs. So all of their first dollar spend is covered at Plum Health, our direct primary care service. So all of their employees are heavily encouraged to go see the direct primary care doctor, us, and we'll take care of any of their concerns. But then they also use like a third-party administrator to help do care navigation and help their employees find the specialist that will take a cash pay service to decrease their downstream costs. Have you found that there's benefits to working with certain TPAs, or have you seen those downstream costs decrease by working with direct primary care with other elements in the ecosystem? Can you talk about that?
Yeah, absolutely. And the answer is most definitely.
Yes.
Right. And I think the biggest challenge can be is my direct primary care partner, are they on site, are they near site? Are we bringing employees to the clinic? Are we bringing spouses and children to the clinic? How do we deal with sort of the freedom of choice component of this, wanting people to not feel forced to go somewhere, but rather incentivized to go somewhere, and then they have that great experience? What I see as the downfall is, I think, the short-sightedness of that this clinic is going to immediately save my plan money, right? Sometimes I've seen where increasing access to primary care, especially in rural places, you start to uncover chronic disease that you didn't know was there. So there can be some upticks in certain things, right? And that's good. You want to see that. You want people who are diabetic to get care. You want people who have high blood pressure to get care. So those things that's good indicators. So it is a little bit more of a long-term play.
Right. So by engaging with direct primary care, all of your employees get access to a competent, comprehensive doctor that has the time to do the diabetes screening or colon cancer screening or order the mammogram for breast cancer screening. So you are going to find some things in that first year, and your costs may be slightly higher, but the idea is that over time, those costs decrease dramatically as people become well managed in terms of their chronic conditions.
Yes, agreed. And then I think the really high performing arrangements are a little bit like what you just described, because I've been doing this in one way, shape, or form for almost 30 years, and I have trouble resolving problems that come up in my family's care and managing insurance and navigating what's the right place to go.
Yes.
So, we high deductible health plans are everywhere. This idea of consumerism in healthcare, and we talk about, you wouldn't buy a TV without knowing how much it costs. Well, it's not the same with healthcare, because we lead with our emotions when we're sick. We lead with our emotions when we are dealing with our family, or sick kids, a sick spouse, and actually understanding what the cost of care is from one place to the next is almost impossible. Yep. And so having your DPC as a place for care navigation and having that trusted relationship, and not having your primary care provider be beholden to one particular hospital system, and having referral patterns going to a place that financially benefits that system, but having care going to the places that are the highest value, best outcomes for the best relative price, not the cheapest price, the best relative price.
Yes.
Helping people understand that, surgery is not always the answer for, musculoskeletal issues, that we want to look at rehab, we want to look at alternatives.
Physical therapy,
things like that. Bringing physical therapy on site. I actually talked to a client about this couple weeks ago, because they have an aging population. Musculoskeletal conditions are their number one cost driver, and they have all of their employees in 3 locations. 2 of them are rural without great access to primary care. Have you ever thought about bringing a physical therapist on site? Like, we don't even need to go into direct primary care yet, but how do you address those needs in a way that's convenient? Start to gain that trust, and then start to look at where do we want to send our MSK cases? Where do we want to, how do we want to refer into specialty care? How do we want to prescribe? And how do we want to prescribe not based on a formulary that is, driven by rebates that benefit the PBM? How do we want to prescribe in a way that is, again, outcomes based?
Yep. For us, we love referring to independent specialists in the community because we know that they can give us a fair price. They're independent, so it's their reputation is on the line, and they tend to be more comprehensive and more caring towards our patients than referring to somebody in system. I'll throw one statistic at you, but many times primary care doctors who are employed in the insurance-based world are seen as a revenue driver for the hospital system. That's why so many doctors' offices are bought out by the big players in the healthcare ecosystem, the Corwells, the Henry Fords, the Ascensions, etc. They all want to own independent clinics so that they get that downstream referral. They know that each primary care doctor is worth $1 million in downstream referrals every year. So it's like if the primary care doctor gives a knee joint injection, that they can only bill for $50 or $100, but if that primary care doctor refers to orthopedics, who then gives the knee joint injection, that's $500 or $1,000, and that 10x difference is valuable to the hospital system, but
Absolutely.
costly to the patient and costly to the employer because it's costly to their health plan.
Correct. And that patient has no actual capacity to be a consumer in those situations.
Indeed.
And, primary care physicians in the traditional model, they have these, performance incentives, and really it's checklists.
Yes.
What percentage of your diabetics are checking these boxes, and they're all prescription-based boxes.
Or referral-based, yes.
Correct.
Yep.
And so, I experienced that personally, and I watched it happening in front of me, and at least I knew enough to say, I'm never going back to this provider again. But most people don't.
Yeah, and I think that's something where having a really well-formed, direct primary care practice with a TPA to help, steer people in that care navigation and get people the best resources possible at a fair price, a reasonable price in the market. May not be the cheapest, but a reasonable price in the market to help them is a best practice, in my opinion.
Yeah, I agree. And I think a lot of it goes back to change management, and it goes to fear. It can be scary to take your workforce, right, and move them from this, I've got my Blue Cross card, I can go anywhere.
Yep.
No one's going to question me. No one's going to direct me someplace that I don't know if I should, where I should go. To now, here's this bespoke arrangement. So we have to be better at helping people navigate. And the key to that actually is the primary care physician.
Indeed.
Right. So if we can look at arrangements, because it's not, primary care physicians in the traditional model, it's not like they're getting paid, such exorbitant amounts that moving to direct primary care, you've got this 1-for-1 cost savings, in my opinion, and you could probably speak to that better than I could. It's about all of these other pieces, like you said, not having to refer to a specialist for certain care. When you do need to refer to a specialist, getting that person to the high value specialist, helping them get to the right pharmacy, on the right drugs, on the right holistic treatment path, which a lot of times involves nutrition and exercise and all of these other pieces besides just checking boxes.
Indeed. And then one step further is we have medications on site, so we're not even sending to a pharmacy, so we save people 50 to 90% on their med spend. We also do the same for lab work. And then imaging services. We're fortunate in this community to have freestanding imaging centers that are right down the street, where we can send people for a knee MRI that might have been $3,000 at the hospital is now $380. So to wrap this up, What are your final thoughts about the market and where things are headed and what you see on the horizon that's exciting to you in terms of helping your clients?
So I think data is the key to all of this. You know, I have a client that has some direct primary care now. They're looking to expand it. And one of the things that we're bringing to that client is an integration of their health plan data and their clinic data.
That's great.
And so, you know, they are with a Buca for their TPA right now. So they've got a carrier TPA partner. They're not with an independent. And part of what I would say too is you don't need to be independent to start doing creative things with your health plan, right? If it's scary to move away from that Blue Cross card, doesn't mean that you're necessarily stuck. You can do creative things with your health plan. It's one path. If you do want to go with an independent TPA, you probably do have more opportunity to get really creative, but that shouldn't be the barrier. Right. You know, there's pros and cons to both models. But being able to really look at data that's happening in the health plan, in the direct primary care, make comparisons of cohorts.
Yeah.
Right, of different people with regard to outcomes, with regard to wellness, and then making data-driven decisions for your population, and then being able to share kind of the love, because you should start to see cost savings. Again, it might not be a year one thing. What you should start to see, though, is trend leveling out. So you're not looking at 15-20% increases year over year, which is where we are right now.
Yeah.
Right? It's more, 5% or less. Sometimes you start seeing, negative trend, but you have to have data.
Indeed.
In order to make those good decisions. And, you have to be partnered with, solutions that will provide you data without putting in, roadblocks or excuses as to why they can't give you that data.
Excellent. Yeah, I think every company should be able to demand their data from their carrier and use that as a roadmap to cost savings. And I think what a lot of companies don't understand is this can be a multi-year process. You can start by adding a creative direct primary care solution, and then you can change your TPA, and then this can be a multi-year transition as you go from fully insured to self-funded. So it's interesting you brought up that Blue Cross Blue Shield card, because we've seen so many changes in the market, 10-20% increases, as you mentioned, but also they're not even covering Zepbound or the GLP-1s anymore. And do customers still have that confidence that comes with every card, as they say? Are you seeing that your big clients are still confident in that Blue Cross Blue Shield card, or is that eroding over time?
I think it's a little mixed, but you're not wrong that the tide's starting to change a little bit. People are more open-minded because they can't sustain these increases over time.
Yeah.
And so it is company by company. I actually have a client that, despite our recommendation to make a change, they took a large increase with their Blue Cross option in order to keep the Blue Cross card that they felt comfortable with, they felt that their employees were comfortable with, and they thought from that employee relations perspective, it was going to be the best decision. So every company is unique, and I think, I want to respect that part of it. I would say more and more, I'm starting to see those organizations that were always blue, always true blue, start to be interested in looking elsewhere, having those conversations. I actually had a client call me the other day, and this is, again, by no means, this is not a Blue Cross bash, right? They have their purpose. And again, I think there's a roadmap for self-funded plans to do creative things within the Blue Cross space too. But I had a client call me because, it's been in the news that they've lost $1 billion this year. So, this is not going to change anytime soon. Blue Cross has to get stable.
Right.
Now, when it comes to GLP-1s, though, GLP-1s for weight loss, like the Wegovy's of the world, Blue Cross was the only insurance company that was actually covering it.
Yeah.
On a self-funded plan, you can do what you want. So that's another reason to be self-funded. You can make some of those decisions for the best interest of your population. So by ending that coverage, they kind of caught up to the rest of the world. But as much as I was saying consumerism doesn't work, here's an interesting example. It's kind of like LASIK. We're starting to see the cost of these weight loss medicines in the market come down. We're starting to see compounding pharmacies that are doing it, less expensive and more efficiently become players in this game, right? So we're seeing a little bit of how the market can influence and how consumerism can work. Now, is that the same thing when you're talking about cancer treatment? No, right? Yeah. That consumerism, that market, you don't have the same dynamics.
Yeah. Another way to look at primary care is perhaps a hedge. When people invest in direct primary care or a doctor on site or near site, it almost becomes like a hedge against some larger downstream expenses. Could you talk about your experience with that or how that looks to you, from where you're sitting?
Yes. So first of all, it's the identification of illness that was unidentified in the population before. One of the things we look at when we talk to our clients and we start looking at their data is we look at not just who's getting treatment, but who's not getting treatment. How many people in your population had no claims? And what is the age stratification of that? So some of it is finding the ticking time bombs and finding them earlier. And yes, you might see an uptick in the number of diabetics on your plan because you've identified them. But that's, again, a good thing because you're not waiting for that catastrophic event. Surgeries are another place, what we call elective surgeries. Anybody who's dealt with back pain or knee pain or hip pain would probably disagree that those are elective. But those sort of, examples of things that you can plan out, you can see coming, you can try to avoid through physical therapy, or maybe you can't avoid through physical therapy. Maybe eventually you do need a knee replacement. Making sure that they're getting to that high value treatment can save a health plan $40,000, $50,000
easily. Sometimes $100,000, right?
Easily. Another example that I've used is just labor and delivery. Having if you have a high risk pregnancy, you probably want to be at the place with the great neonatal center. But if you have a normal uncomplicated pregnancy, the difference between a vaginal birth and the price of a vaginal birth and from facility to facility can vary by $10,000, $20,000, $25,000.
Yep.
And those things add up over time on a health plan. Yeah, we can focus on the $1 million hemophiliac, or we can talk about these emerging gene therapies. But what really matters to the nuts and bolts of a health plan is some of these other things that add up over time that can be really impacted by direct primary care and having that physician relationship and the accessibility to a physician.
Right. Yeah. Preventing ER visits, preventing urgent care visits, reduced referrals to specialists because DPC doctors actually have the time to be comprehensive. I could see how all of that adds up, and we run the balance sheets for some of our companies who are looking at this, and we go line by line and show them conservatively, if we reduce your ER visits by 20%, this is how much you save, but we know that DPC can save, reduce ER visits by 40%. So we can calculate that for folks, and it's helpful to illustrate that.
Absolutely.
We've had a great conversation, and I want to know something. There's so many problems in this insurance space, so many friction points. If you had a magic wand and you could resolve like one or two things or add one or two things to every employer's health plan, what would you do?
Well, both of those things actually can be solved with direct primary care, interestingly enough. One of them is pharmacy.
Yeah.
So I would really unravel every traditional pharmacy arrangement that exists within a health plan. So you need to be with pass-through, transparent pharmacy benefit manager who is not driven by rebates and who kind of, treats the whole market fairly, understanding that, the pharmacist is an important component in this, but also that we need to get people to the highest value pharmaceutical solution all the time, 100% of the time. And then the second piece of it is data and transparency. So there is a lot of waste in the medical system, the healthcare system in general, and you can find it in every pocket. And so why are we over prescribing, over testing? Why are we sending people, to the wrong place for care? We're sending them because, again, of these alignments within, hospital systems and primary care.
Yeah, misalignments currently.
Misalignment, correct.
Yeah. I really want to thank you for helping illustrate some of these hard points, some of these pinch points as people make this transition, and really making this a little bit more clear for folks. So
Thank you.
Thank you so much for your time.
Thanks for having me.
You're welcome.
Yeah.